On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Well, it's really my pleasure on behalf of the master trial investigators to present you for the first time in the world, so to speak, before the hotline, the results of this trial. It's a prospective randomized multi-center evaluation of a Micronet mesh-covered stent in patients with acute myocardial infarction with ST segment elevation. The hospital got a grant support, so I have to wait until this changes automatically. I have no influence here in this slide. But otherwise, okay, here it is. Well, actually, it's not a stent. Everybody called it a stent, but it's not a stent. It's an embolic protection device. It's a mesh graft, as you can see here, a mesh graft from PET, polyethylene. The stent is only a device to deliver the mesh and not the other way around. In the first phase, we used the stainless steel stent, then later on the cobalt chromium stent. The cobalt chromium is a little bit more flexible with thinner stent struts, but what's important is that the sleeve, the embolic protection part, is the same. It is a very tight net, but it still leaves open side branch access. Well, this is the basic concept. It's a randomized trial. The control group you see on the left side, so it was left at the discretion of the operator. You could use a bare stent or you could use a drug-eluting stent, whatever, and the active group was the PCI with the M-Guard mesh delivering stent. There was some sub-studies. I will shortly go in this. Follow-up was 30 days, 6 months, 1 year, but the primary endpoint was between 60 and 90 minutes. So actually the next day after PCI, the primary endpoint was already available. TIMI flow was somewhat different in both groups. For the sake of time, I would not go through all these details, but please note that the average vessel diameter, RVD, was 3.2 in both groups because 2.5 stents were not yet available, only 3.0 and 3.5 stents. So this explains why the vessels were rather large. So this is the primary endpoint. Complete, partial, and absent ST segment revolution in the resting EKG. Over 70%, it's defined as complete. And here's the M-Guard results, and as you can see, more than half of it had complete ST segment resolution, and the control group was significantly less. So there's actually a shift from, with the M-Guard stent, from partial to complete ST segment resolution. And interestingly, the red curves are the same. So there's about 16-17% of patients who have no complete or no ST segment resolution. You cannot help them with either stent, with either device, but the rest of it, over 80%, you can help about, what's the difference, about 10-13% of the patients. Okay, what about the clinical outcome? Of course, ST segment resolution should kind of reflect the clinical outcome. Here you see the mortality. 4 patients died in the embolic protection device group, whereas in control stent with, this is MACE 5 here, but if you look at cardiac mortality, this is even more important. No patient died in the M-Guard group, and 4 patients died in the control group. Well, it hardly missed the significance. You can do some subgroup analysis and find a P005. But nevertheless, anyway, even if it would have been significant, it would have been underpowered for a clinical endpoint. But it's an interesting, it fits to the trend. Here's the result of the MRI sub-study. I will not go into details. You have the slides. It's only a small group of patients with infarct size and so on. So we can conclude that among patients with acute STEMI undergoing emergent, which is primary PCI, within 12 hours after symptom onset, the M-Guard embolic protection device with this mesh covered stent, but again it's not completely covered, it has holes, compared to conventional metallic stents, either bare stents or drug-eluting stents, resulted in superior rates of epicardial flow and complete ST segment resolution. Of course, this was a surrogate endpoint, and we need a larger randomized trial to verify these hypotheses or these findings in a larger trial with death and MI as a primary endpoint. So as the embargo will be lifted later, you will have the full paper online, downloadable, and the JAC website. Thank you. I still have 25 seconds.
Thank you. Thank you very much. You did a great job. Thank you. Okay, well, we have this paper is now open for any questions. Yes, Rob, please. Yeah, it's nice to use the microphones, please. Thank you.
Hi, Dr. Silber. I have a question just sort of about the patients in this study. Are STEMI patients particularly vulnerable to plaque embolization during PCI in particular, and is that why you studied them?
Yes, especially the STEMI patients have a lot of thrombus in the artery, and the problem is sometimes the artery is occluded or it's very highly narrowed, but it's not like a stable lesion like you heard in the first trial, in the FAME trial. These were stable lesions. This is highly thrombotic, so if you push a balloon through this thrombus, you have a risk of dislodging the thrombus to the peripheral vessels, and there's nothing you can do about it. Once you dissolve a thrombus and the thrombus goes downstream, it's lost. I mean, there's nothing you cannot do any intervention to heal this. So you have to prevent it.
Okay. And my second question just pertains to the complete ST segment resolution. In terms of that translating down the road in terms of clinical endpoints, would you have expected to see an MRI difference within 3 to 5 days? And basically, how do you expect the segment resolution to play out down the road?
Well, to me, as a clinical cardiologist, I think the concept of reducing or making faster ST segment resolution, it's faster, it's a matter of time, extrapolates to mortality. The MRI study, sub-study, it's a small number of patients. It's complicated. You really have to look at the images. And it's a mixture between small vessel, microvascular obstruction, and late enhancement. And if you have a lot of experience with MRI images, you will see that the inter-observer variability is also higher. The MRI today is called the gold standard for infarct size, but I'm not personally so sure about that. I want to see mortality data.
Yeah, absolutely. Mortality data is great, but just to protect the MRI group, I think MRI is actually a gold standard. The question is the timing of the MRI. At 3 to 5 days, we know there's still a lot of edema around the myonecrosis, and so it may very well be that that's not the best crucial time to look at it. And in a small population like this, I don't think you can really say anything. And I think that's an important message regarding the MRI. And the lack of a benefit at 3 to 5 days does not concern me personally. I think the ST segment resolution, which is a good marker of mortality, we've shown that in the Horizons AMI study, large numbers of patients with ST segment resolution greater than 70%, excellent results and a good translation to improve mortality for those patients, but we have to prove it, as you said, in a mortality study. Anyone else have any other questions? Please introduce yourself.
Crystal Fenn with MedPage Today. I wanted to check the mortality that you showed on the slide said it was cardiovascular related mortality, but in the paper it suggested that it was all-cause mortality, the 0% versus, was it 1.9 or 0.9%?
Well, the mortality I've shown here was total mortality. It was 0 versus 4. I mean, again, it's small numbers. And I think what the goal is not as significant or which mortality is. It goes in the right direction. That's the point, you know. So it goes along with ST segment resolution. And again, we need larger trials to really make an issue on mortality. But I'm happy if results and parameters go in the same direction as expected.
Okay.
Actually, mortality was 0, so
Zero,
whether it's
zero.
cardiac or overall, it's a 0 mortality. And then there was 1.4%. I think all of the deaths were cardiac deaths
Okay.
on the other side. So I think that's
I have
clear.
a question.
Yes, question from the panel.
How much of a difference in ST segment resolution do you personally think is going to make a clinical difference? I mean, I agree that ST resolution is a good endpoint. We've all been part of studies doing that, but you know, for a difference to make a difference, it has to really be a difference, and that's the question.
The 70% cutoff was based on previous studies.
No, I agree with that,
yeah.
but the difference between the two, between the two arms, how much of a, what sort of magnitude would you think will translate into a clinical benefit?
Well, the bigger the better, of course, but I mean, we had about a 13% difference, and there was a trend of decreased mortality. So if we have a larger number of patients, maybe 13% is enough to show a significance. If you have a bigger difference, of course, it would be better.
I mean, I think that's an excellent question, but you know, Bernie, no one really knows what that level is, and it may be different for different patients, right? And it may have to do with what do you come in with, how much LV do you come in with, how much do you lose, and how much can you get, you know, can you reserve and preserve?
That's what
right?
I think. I think, you know, 15% or 13% of an infarct with an area of jeopardy of 30% in the left ventricle may be really significant. But if the jeopardized area is only 5% or 10% of the left ventricle, then 13% will not make a difference.
Yeah, but I'll take 13%, I think.
wouldn't-
We'll go, Dean.
Brief question. Any
Well, in this study, just to remember, this study, it was predominantly larger infarct areas
Right,
because
these
we had
were
the larger
large
vessels.
infarcts, Yes.
Sigmund, any supportive data with respect to quantitation of infarct size with enzymatic analysis that could have been supportive of the difference between the groups?
Yeah, but we will look into that still. But personally, I think we made 2 points in the study is to bring to awareness of the problem with the thrombus that you just, the major goal is not just to open the vessel. I mean, you get a beautiful result. It was occluded, you open it up, and the patient is happy, and the physician says, I'm the greatest, I opened up the vessel. But the point is, did you open up the vessel without embolic events in the periphery? I mean, you have to look at the peripheral vessels. This is one point.
Last comment, Dr. Faxon, we're behind.
Yes, I'm just going to come back to the question where I think what somebody in the audience asked about mechanisms, because this is a small study, it's a pilot study, it's a proof of principle study, and you suggested the hypothesis that it traps the clot and prevents distal embolization. Is there any kinds of signals within the study that makes you think that's actually true? And there wasn't a difference in MI. Maybe it wasn't sensitive, it wasn't powered, all those kinds of things. Did you get greater benefit in those who had a lot of clot? Did you see no reflow higher in one group than the other? Other things that might make you think distal embolization, in fact, is the mechanism.
Yeah, and there was a significant improvement in TIMI flow rate, and I think that's what we have. Myocardial blush maybe is not such a good tool, but TIMI flow rate I think was significantly better in the MGOT group.
And actually, on some of the early OCT studies, there's been evidence of trapped clot behind the struts when you look at acute OCT. So it makes you believe that there might be something to that. But you're right, and the TIMI flow is the evidence for that. So thank you so much.
Maybe one short
Yes,
comment at
last
the end,
comment.
because I had 25 seconds left.
No,
for
but
my-
not really.
Okay.
We're 10 minutes behind,
One-
and Irma will
No,
have my head.
one comment. There were many studies with distal embolic protection devices in acute MI which were negative or even deleterious. So I think it's important not to bring an umbrella behind the thrombus to catch it, which didn't show to improve. But this concept is different. You go in, little predilatation, and you trap the thrombus, and then you do the work. So it's a different
Wonderful.
concept.
Thank you very much,
Thank you.
Dr. Silber. Please join us.